This video is a demonstration of passive mobilization for the knee joint for knee flexion. For this demonstration, first disclaimer, this is for professional training for physiotherapy only, not for patient. And also, when you apply this technique, need to be based on your clinical reasoning and patient condition. And for knee mobilization is based on the Maitland theory. And so this assume is purely joint problem. If any soft tissue problem, you need to incorporate with other treatment as well. For knee flexion mobilization, then sometimes it's due to the injury, post-fracture, post-ACL reconstruction, the swelling restricts from knee flexion. This for knee joint, although we have mentioned that it's mainly for joint stiffness, but a lot of cases due to the active muscle guarding. Okay, so we will do the knee flexion mobilization to solve this problem. To start from the beginning, for example, right after ACL reconstruction or after the fracture, the knee flexion restriction can start from very early, just at 30 degree, 40 degree. So the starting position, we can just lift up a little bit higher and then do it this way for initial range. Actually, sometimes a lot of cases are due to muscle guarding. For the initial knee flexion mobilization, for therapists, you don't need to even push. You just need to give them security for the patient and let them actively bend themselves, even more effective. So the patient will not have any muscle guarding against your force. Try to incorporate them to use their own force first. Then start from later stage. Another hurdle is 90 degree. In the 90 degree, the involvement of the patellofemoral joint getting more significant. So beside the tibiofemoral joint, we also need to consider the patellofemoral joint. We can use the mostly and the knee superior gliding, or use the whole hand base of the palm, hold on the inferior pole of the patella, push the upward force. Of course, mostly due to lacking of superior glide, but sometimes can be also excessive lateral tilt. We want to promote the medial glide as well. We can also do it this way, use the fingers. Okay, this for the patellofemoral joint, but also for tibiofemoral joint. Now we hold it this way. We can also do more flexion mobilization accordingly. Okay. Sometimes we put the hand here because the patient is restricted by 90 degrees. We need to comfort them to put the hand to avoid suddenly excessive too much bending, progressing too fast. So we'll put the hand here to block it, to restrict the movement, or use the hand even more. Okay. Then go to the late stage of the flexion mobilization, if about 5 to 10 degree necking. Sometimes you need to ensure the hamstring muscle and the quadricep muscle have normal flexibility and normal activation first. Then we get the soft tissue problem, we do more mobilization. We can add some accessory movement such as anterior posterior glide of the tibia on femur. Open your hand. Use it as possible. This anterior to posterior glide, tibia on femur also can promote knee flexion. And also end of the range knee flexion. For further advance, for some colleagues, if you have attended the training of the Mulligan course, we can do some medial glide mobilization or lateral glide mobilization, but make sure you attend the training properly before you apply the technique. Those are the possible knee flexion mobilization manual therapy demonstration.